معانا الدكتور هيبقى ان شاء الله الفيرست ليكتشر هتبقى colon expanding immunotherapy beyond MSI and DMMR tumors. معانا الدكتور محمد إمام استاذ معهد الاورام في معهد القومي للاورام، ودكتور حسام زوام، ومعانا الدكتوره نوران الروبي كمودريتور.
او good evening everybody. first of all طبعا اولا شكرا دكتور احمد والدكتور صلاح وكل الاداره مستشفى الشيخ زايد التخصصي على الدعوه الجميله ديت، وشكرا لكل الحضور يعني ادونا الفرصه ان احنا ان احنا ندسكس بعض الانفورميشن، وبالذات في one of the most common disease زي الكولون كانسر. وشرفني طبعا اكون مع زميلي وصديقي الدكتور حسام، اخ فاضل يعني، ومن الناس الاميننت في مجالهم في مجال الاورام. هو مش هيبقى ديبيت اكتر منه ان هو هيبقى جاست alternating information ما بيني وما بينه، ويا رب ان شاء الله ان احنا نقدر نوصل مع كل لاحسن حاجه. والدكتوره نوران ان شاء الله هتبقى مودريتور للسيشن، والدكتور حسام يقدم نفسه. اتفضل.
السلام عليكم. السلام عليكم. طبعا نشكر دكتور احمد عبد الهادي على الدعوه الكريمه، والحقيقه نتشرف دايما بوجودنا مع ليدرز اكاديمي في كذا ايفنت. ده يمكن يعني الايفنت السادس ليهم، ف يعني دايما بنتواجد معاهم ونتشرف دايما بوجودنا معاهم. الحقيقه ليدرز من الاكاديميز الفيري بروميسنج، وبتحرص دايما على التريننج والاديوكيشن. انا حسام زوام، استاذ مساعد كلينيكال اونكولوجي في القصر العيني. طبعا مشرفني النهارده اكون مع اخويا وزميلي دكتور محمد امام، استاذ في معهد الاورام. احنا هنتكلم عن immunotherapy في الكولون كانسر، وزي ما دكتور امام قال مش هيبقى ديبيت قد ما هو جاست يعني ايه نحاول نوصل ل the best approach for MSI high metastatic colorectal cancer disease.
دكتوره نوران.
اولا احب اشكر فرصه ان انا موجوده وسط حضراتكم النهارده، واشكر دكتور احمد عبد الهادي على الفرصه اللي اتاحها ان انا اكون موجوده مع حضراتكم ومديريه السيشن بين اخواتي دكتور محمد امام ودكتور حسام الزوام. انا دكتوره نوران محمد، فيلو وكونسلتنت اوف كلينيكال اونكولوجي في احمد ماهر تيتشنج هوسبيتال. خلينا نبتدي ان شاء الله.
First of all, we are discussing now the role of immunotherapy in MSI high metastatic colorectal cancer, because we are now in the era of precision medicine and we are moving forward regarding either target therapy or immunotherapy. First of all, colon cancers, all of us know it is the third in incidence between the cancers, and even the third in incidence in mortality regarding the cancers. So it is one of the big 5 killers in cancers like breast, like lung, etc. So management of those people or those population should be discussed in multidisciplinary approach, just as to increase the outcome and to get the optimum outcome of the patient with metastatic colorectal cancer, because we are not dealing with single disease, we are dealing with multi parameters and multi variables related to patient characteristics and even the tumor characteristics. And now we have the new molecular characteristics related to the disease. So like we are not dealing like with all patients with chemotherapy like previously treated. Now we are treating according to different alteration and different molecular aberration. Now my dear colleague Dr. Hossam will discuss how the molecular alterations in this disease can impact the outcome and predict the response to the treatment.
طبعا الكولوريكتال كانسر از heterogeneous disease، وفي many parameters هتأفكت التريتمنت زي ما دكتور امام كان قال. من ضمنها البايو ماركرز او الحاجات اللي احنا قايلينها دي. These are the minimum biomarkers that need to be done for patient with colorectal cancer. RAS mutation طبعا RAS mutation is only predictive and prognostic. Now we have the anti-KRAS, the anti-KRAS G12C targeted treatment. Also we have the G12D vaccine. Previously we need to know just KRAS or mutant or not. Now you have to know which type of KRAS, either G12C or G12D, because this will tailor the treatment. The BRAF mutation is extremely poor prognostic. Almost half the survival of other colorectal cancer patients. Median survival of the BRAF mutant with conventional therapy ranges from 12 months only. Others the range from 30 to 50 months. This can be completely reversed by the use of BRAF inhibitor plus cetuximab plus chemotherapy. Also, the BRAF mutant patients have very unique characteristics and very special site of metastasis. Very rare sites other than colorectal cancer. And the BRAF mutant patients can metastasize to the bone, the peritoneum, the brain. This will affect the decision during medicine. If a BRAF mutant patient come to your clinic with headache, you have to do MRI to see if it has brain metastasis or not. Others, you can just prescribe brufen for the headache. For BRAF mutation is very important. The MSI high is the core of our talk today. It's also an important biomarker because some patients will be cured with immunotherapy. The HER2 amplification is also a growing biomarker, and it should be done in colorectal cancer. We have now targets for the HER2 mutant patients, the tucatinib, trastuzumab, and chemotherapy. Also the TDXD, not in the first line, but they are in the second line, and there are studies for using them in the first line setting. MSI high is a very unique biomarker. The incidence of MSI high is about 5% in metastatic colorectal cancer patient. It can be tested using immunohistochemistry or PCR or NGS. MSI high is very unique because in stage 1 colorectal cancer patient, it is good prognosis. In stage 2, it's good prognosis. In stage 3, it is indifferent. It has no prognostic impact. And in stage 4, MSI high is poor prognosis. So how can just one biomarker be good prognosis in stage 2 and poor prognosis in stage 4? This is because the mutations that occur with MSI high in the metastatic phase are very aggressive mutations that tend to increase the cell proliferation, the cell survival, and inhibit apoptosis. While the mutations that occur with MSI high in stage 2 are mutations actually that prevent metastasis. So it is an important biomarker. In stage 2 patients with MSI high, you can prescribe them follow-up only without chemotherapy. You can test for MSI high, as we have said, with the immunohistochemistry, with PCR, and with NGS. You should not interchange the biomarkers of colon. TMB is different than MSI high, different than PDL1. Each biomarker has specific features and specific characteristics. PDL1 patients are the highest percent, 70%. MSI high, as we have said, 3 to 5%, and they are not interchangeable. The patients with TMB, for example, the incidence is 8%, and TMB in colon is not like other tumors. We can discuss this later. These are the different tests that you can do to test the MSI high: the PCR, the immunohistochemistry, and the NGS. If we have all the facilities, we should start with immunohistochemistry for the MMR status, and then proceed to the PCR and the NGS later on, if we have all the facilities. If we don't have the NGS, we do the MMR by immunohistochemistry only. The problem with MSI testing is that it can be false positive or false negative. In the large trials, in all the large trials of metastatic colorectal cancer patients, the incidence of false results with MSI high ranges from 10 to 20%. If these results are tested locally and revised again in the central lab. So the MSI test is a bit difficult, and you should be sure that your pathologist and your lab can test this test correctly.
So before moving to the next slide, if we have a patient assessed by immunohistochemistry, do you need to confirm by PCR or even by next generation sequencing?
If a patient is tested by immunohistochemistry and the results, this patient should be retested by using PCR or NGS? This is the question of Dr. Emam. This is a very important question. If you have the facilities, you should do this for all patients. If you don't have the facilities, you have to tailor your treatment. If the patient appears to be just PMS2 isolated loss, for example, MSI high, MMR with PMS2 only isolated loss, this patient should be tested by NGS or PCR, because this patient can be MSS if you retest by the immunohistochemist. So if you have the facilities, you should do both. If you don't have the facilities, you should tailor the test accordingly.
So now coming to the real world practice, how to manage the patient with...
I have a question.
Okay.
Sorry. Do you recommend the testing BDL1 or the tumor mutational burden before the usage of immunotherapy for metastatic colorectal cancer? Do you want to assess it for even the MSS stable?
Okay, for the metastatic colorectal cancer patient, the TMB is not that important, because the trial that results in TMB, in acceptance of immunotherapy for the TMB status more than 10%, did not include any patient with metastatic colorectal cancer. This study did not include patients with metastatic colorectal cancer, most probably because the TMB status of the colorectal cancer is not on the cutoff of 10% like other tumors. It should be higher, about 20% or more. TMB?
The colon cancer, Prof. Mohamed Abdallah, the colon cancer considered a cold or hot tumor?
Cold tumor. Except for the consensus subtype 1, now characterized by the immunogenic structures. The immunogenic signatures بيكون فيها MMR deficient اللي هو correlated with MSI high, بيكون فيها BRAF mutation. All this considered as a part for the immune scenario. We don't encourage to do even the test for patients with, apart from the location, apart from the sidedness of the tumor, because rarely you will find tumor with left side colon cancer to be sensitive to the immunotherapy based on the MMR deficiency. Okay, they are there, but it is not. What's really of importance in the, when we talk about the molecular signature of the tumor, is to identify the hypermutated form of the disease, BRAF and PI3K. This is found in the majority of patients with right-sided tumors, and when you find the BRAF mutation, look for the PI3K, because PI3K, when it is mutated, even if you are going to imply the BRAF inhibitor, for example, for this type of tumor particularly, when combined with anti-EGFR, it will not yield any response, because we have a crosstalk between the PI3K and the BRAF. This is very important and should be taken into consideration. Also, if you are going to give, or you consider that this patient is having a RAS wild type or RAF, the super wild type, before, my advice, before you go for the anti-EGFR plus chemotherapy, look for the HER2 amplification, because if you have a wild RAS and you will give anti-EGFR while the patient is having amplified HER2, no effect on the anti-EGFR. So we are making constraints for the use of targeted agents nowadays based on our better understanding of the molecular stage of the disease. So, BRAF mutation, MSI high disease, this is for the consensus molecular subtype. And here you have the leisure to go for immunotherapy if you want. But we don't comment much about the BDL1 CBS positivity, because colon cancer in general is considered as an immune-deficient disease.
Yeah. Yes. Before starting any treatment now, we must do all the HER2, MSI, BRAF, and then tailor our treatment according.
majority of cases لو احنا بنتكلم عليهم هم هيبقوا عندك من 40 ل 50% في الفيرست اتاك هيكون عندهم راس
Yes.
العيانين اللي هم الراس او الراس كيراس اللي هم سوبر وايلد disease, if you have BRAF mutation, I will be somewhat skeptical about adding anti-EGFR, because we have contradicting data for this particular issue. Many of the trials, meta-analyses, told that no harm, you can go. This is not a contraindication. Why? Others said that no, this group of patients are having poor prognosis by definition, and they are not going to show the full load of benefit of adding anti-EGFR to the chemotherapy backbone. And if you are intending to achieve downsizing, for example, of a liver tumor to be resectable at any point, don't expect that you could have this benefit when you have HER2 amplification. It's about 3 to 4% maximum of the patients, but nobody knows. And it's a simple test, it can be done. Still, we are not that forced to go for the NGS so far that we are seeking for the MMR, it's an immunohistochemistry. BRAF, V600E, also it's an immunohistochemistry. And for the HER2 amplification, it's also an immunohistochemistry. So they are simple tests, they are not much expensive, but it can save the patient from being unnecessarily exposed to targeted agents, very expensive, and what's really more important, that you are not going to get any benefits.
Thank you so much, Dr. Mohamed.
Thank you, Mohamed.
Thank you so much, Dr. Hain.
So
moving to the case.
now coming to our clinical case, we have a patient with right-sided colon cancer with liver metastasis and have MSI high. So do you prefer to, or what is the optimal treatment in the first line? Doublet plus bevacizumab, or triplet plus bevacizumab, or single agent pembrolizumab, or combination nivolumab and ipilimumab? Could you raise your يعني مين اللي هيختار؟
These are all the options, and we will discuss some how to choose between these options.
Okay. So now
بس يا جماعه
اتفضل
لو اذنوني،
اتفضل.
انا هنا اللي انا فاهمه ان انا بتكلم على
MSI high.
liver limited disease, MSI high, right? Am I? You neglected totally to talk about the anti-EGFR monoclonal antibodies, because I know it's
Right side.
but my intention of the treatment will guide my
Yes.
decision.
Yes.
If I am talking about downsizing or tumor shrinkage or conversion therapy based on many of the key opinion
Yes.
leaders and even by the ESMO and we have the RAS wild type or RAS wild type, you can go for chemo plus
Yes, definitely. But we would suppose that this patient has multiple irresectable liver
Metastasis
metastases,
not
and we
conversion.
suppose also that this patient is generally fit and can tolerate any of the therapies. So this patient is not a clinical case scenario, but just an opening slide for our presentation.
طب استنى، ما حدش قال الاجابه هتبقى
ما احنا هنقول
احنا
هنقول بقى
عاوزين
مين اللي او مين اللي لا، يعني هنقول ليه لا.
دكتور هاني مثلا تختار ايه؟ رأي حضرتك؟
يعني from the guidelines they started with immunotherapy as a first line in this in this patient
Which one?
and pembrolizumab.
Okay. دكتورة نوران.
I will go for Pempro also. But I want to ask a question when to use dual
We will ask the same question at the end, and most probably you both will change your minds. ايوه.
مين اللي يعني هو liver metastasis بس
irresectable.
احنا مش فول كيس، مش فول كلينيكال كيس، بس just opening for
يعني
the
what's your
presentation.
intention of the treatment?
Palliative treatment, metastatic.
Metastatic.
Palliative.
Yes.
Palliative patient generally fit.
مفيش tumor, high tumor يعني ال high tumor burden that is not affecting your patient's symptomatology.
Yes, the patient is generally fit. All his labs, the liver functions, kidney functions are all normal. The patient is has no comorbidities, 47 years or 45 years old. We suppose that this patient is generally fit. So we will ask this same question at the end of the presentation. Okay. The anti-EGFR is not that effective in the metastatic colorectal in this case because it's right-sided and it's MSI high. So we exclude we didn't mention the anti-EGFR therapies. Also the triplets, we have the meta-analysis of triplet versus doublet FOLFOXIRI-BEV plus or FOLFOXIRI-BEVA versus the doublet plus BEVA, and it favors in the triplets in the right side and the left side in RAS mutant patients, but not in MSI high patients. Why we should use immunotherapy in this case? Because immunotherapy is the most active treatment in the MSI high population. These MSI high population have high tumor mutational burden, have strong immunogenicity, and have multiple neoantigens to be presented for the immune cells to identify and kill the cancer cells. So the options in the MSI high cases are either the immunotherapy single agent, either pembro or dostarlimab as single agent or cemiplimab as single agents, or the dual immunotherapy, the anti-PD-L1 and the anti-CTLA-4, the nivo-EP, for example, is the combo we'll discuss here. The first study we'll have to discuss is the KEYNOTE-177. This study randomized 300 patients with metastatic colorectal cancer to either immunotherapy single agents, pembrolizumab, versus the standard of care at that time, the FOLFOX, or FOLFIRI plus BEVA or cetuximab. It randomized 300 patients to in a one-to-one fashion for the pembro as first line, or for the chemo-targeted therapy in the second line. And this is the flow of patients. Sorry. This is the flow of patients, 150 in each arm. With somehow some patients crossed over to the chemotherapy, to the immunotherapy arm from the chemotherapy arm. This it's not only some patients. 60% of patients crossed over from the chemotherapy to the immunotherapy arm, and this may affect the survival, as we will see later on. This is the PFS. The PFS shows very high trend favoring the immunotherapy. The median PFS with the immunotherapy is 16 months. The median PFS with the chemotherapy is only 8 months, with a hazard ratio of 0.45, much favoring the immunotherapy in the first line. Also, the duration of response is highly tending towards the use of immunotherapy in the first line. This is the overall survival. The overall survival also favoring the immunotherapy, but it's not statistically significant because the alpha was put in this study as the alpha ratio of more than 0.225, but the p-value developed 0.035. So it's not statistically significant, but it may be of clinical benefit. So the overall survival is also favoring the immunotherapy, but is not statistically significant. And this may be because, as I have said, that 60% of patients crossed over from the chemotherapy arm to the immunotherapy arm. Also, the PFS2 is very important because it does not tell you only the effect of the first line. It tells you the effect of subsequent line, and it tells you the effect of doing immunotherapy in the first line. The PFS2 is the time from the randomization to the progression upon the second line treatment, and it's also favoring the immunotherapy, the pembrolizumab, the median PFS2 54 months versus 24 months with the chemotherapy arm. So the use of immunotherapy in the first line affects the survival and affects the progression even in the second line or the subsequent therapy. So the PFS2 also in favoring the immunotherapy. But there are a percentage of patients that do not respond to the immunotherapy, and we have seen that from the curve. From the initial 2 or 3 months, patients with the chemotherapy drop below the patients with the immunotherapy dropped below the patients with chemotherapy, and we found that 30% of patients progressed on the immunotherapy or did not respond to immunotherapy. So we have to identify who are these 30% who will not respond to immunotherapy, even if they are MSI high, but they do not respond initially to the immunotherapy and even progressed on the immunotherapy. We have to identify this subgroup of patients. The adverse events of immunotherapy are well known: inflammation in any subsite, skin manifestations, diarrhea, colitis, hepatitis, thyroiditis with hyper or hypothyroidism. These are the side effects of immunotherapy. And the conclusions from the KEYNOTE-177 study is the PFS is much favoring the use of immunotherapy in the first line arm with hazard ratio of 0.45 in favor of the use of the immunotherapy, the single agent pembro, and the overall survival is also trending towards the immunotherapy. It's not statistically significant, but it is maybe of clinical value, and the duration of response or the response are more durable with the use of immunotherapy. Also, the PFS2 is more is an important endpoint, and it favors the use of immunotherapy in these MSI high patients. Moving to the other study.
Thanks, Dr. Hossam. Now, Dr. Hossam showed how the single agent pembrolizumab showed improvement in the survival and even the tolerability regarding patients with MSI high. Now we are discussing the dual inhibition for immune system in the CheckMate 8HW and the rationale for a combination of PD-L1 plus CTLA4 inhibition just to increase the priming of the effector T cells and also to decrease and to enhance the T cell activity and even like to increase how to overcome the resistant mechanism to the immune response. And as we see on the right side, show the efficacy of the doublet inhibition compared to the single inhibition. Our study CheckMate included the patient. It is a multi-center study, just included patient with MSI high as a de novo and randomized the patient to nivolumab plus ipilimumab and used ipilimumab for only 4 doses compared to the single agent nivo compared to the standard of care chemotherapy plus target therapy as investigator choice. And the primary endpoint, it is a co-primary endpoint, progression-free survival regarding nivo-ipi compared to the nivo and also nivo-ipi compared to the chemotherapy. And our secondary endpoint, progression-free survival to overall response, quality of life and safety. This is how the patient characteristics in those population, and most of those population with good performance status, as we see the liver metastasis about 40% in most of 3 arms, and even the patient have MSI high. And in this study, like one of the requirement for this study to central assessment of MSI, not only depending on the investigator assessment, but we need to confirm the MSI high for those patients or not. Now coming to the result regarding the progression-free survival, nivo-ipi compared to the chemotherapy, as Dr. Hossam will say, also pembrolizumab have progression-free survival at 2 years reaching about 48%. But now in our trial, we have over progression-free survival 72 compared to 14 with big separation of the curves. And not only have a progression-free survival benefit, but also the crossover between the 2 arms as the start in the first 3 or 6 months. As we see in the Keynote 177, we have not overlapping, crossing the curve, have a higher efficacy of chemotherapy compared to immunotherapy pembrolizumab, but they're not present, only overlapping. But we can illustrate or explain the rationale because we have about 13% of the patients that are inconcordant with MSI when centrally assessed for those patients reaching about 15.5. Regarding the efficacy of nivo-ipi compared to the nivolumab as a single agent, only also showed improvement in the progression-free survival reaching 68 compared to 51, and also nivolumab has still higher efficacy, but we don't have the final result compared to the chemotherapy. Regarding the subsequent line or PFS2, as Dr. Hossam said, like we see how the immune therapy as a first line showed the tolerability and even the efficacy of subsequent lines after using immunotherapy in the first line, and also made the primary primary endpoint regarding improvement in the progression-free survival. And also we have ASCO update in 2025 showed improvement in PFS2 at 3 years, as we see 80% compared to 66%. Regarding the response rate also, as Dr. Hossam said before, we have 45% of patients showed overall response rate compared to the chemotherapy 33%. But in our study, as we see, showed overall response rate reaching 71, and in single agent nivolumab 58%, and also have patients showed complete remission reaching about 30%. Another trial, CheckMate 142, showed the same overall response rate reaching 71% and complete remission about 20%. Coming to the quality of the life, in this trial, this trial showed improvement in the quality of the life and health-related improvement. Also, Dr. Hossam say we have improved quality of the life in our, but in our study it was a primary or secondary endpoint, but in Keynote 177 it is exploratory endpoint, not pre-planned from the start. Now coming to the subgroup analysis of patient receiving dual combination, we have a patient with liver metastasis, and when coming to the liver metastasis, as we saw, the dual combination showed improvement and higher efficacy in liver metastasis compared to the single agent nivolumab. Coming to the safety and the adverse event of combination, most of the adverse events were controlled, and no new signal data regarding the toxicity, and also the discontinuation rate regarding the severe adverse event was 16% compared to 8% in the nivolumab. But when come to the chemotherapy, the discontinuation rate reaching 93%, but most of the discontinuation rate due to the progression and even due to the toxicity compared to 16% in the dual inhibition by nivolumab as we see. So my conclusions regarding this trial, the patient with MSI high metastatic colorectal cancer, nivolumab still showed improvement in the progression-free survival and PFS compared to the chemotherapy and also compared to the nivolumab, and no new safety signals were noted in nivolumab, and also we concluded that support nivolumab especially as a standard of care in patients with MSI as first line. Now coming to my questions, first questions, do you change your mind regarding this? Yeah. Overall survival not maturing, not matured till now, but we have trend to improvement in overall survival.
So if we have all the facilities, how should we choose between single agent immuno or doublet immuno? If the patient is, in most of the patients, if the patient is clinically fit and we don't have financial issues, the patient does not have comorbidities, we could go for the doublet, the nivo-ipi. But if the patient, for example, a patient has inflammatory bowel disease and developed colon cancer with metastasis, you should not use IPI or you should not use CTLA-4 inhibitors because they will increase the IBD. So in this case, you can go for single agent immune. Also, the doublet has much higher toxicity, so you should give it for fit patients. The doublet is much higher cost, so if you have financial issues, you can go for single agent. And in the study of CheckMate 8 HW that Dr. Emam said, we see that the CR rate with Nivo single agent is 28%. The CR rate with Nivo-EP is 32%. So if we have a biomarker to identify which 30% of patients will go in a complete remission with single agent immuno, I think we should go for single agent immuno, but we don't have this magic biomarker yet which will identify those categories of patients. So this is our final slide. The MSI high metastatic colorectal cancer cases, you can go for you should go for immunotherapy, either single agent, pembro, cemiplimab, dostarlimab, and other single agents, or you can go for doublet, the nivo-ipi. It's also worth noting that in the second line, if patient received immunotherapy in the first line, in the second line you can go for a combination of nivo and ipi. And with this, هو approved first line بس يعني mainly في الريكتال كانسر. في الريكتال كانسر MSI high في الريكتال كانسر you can go for dostarlimab. هم عندهم كذا اميونو كمان يعني توريبيريماب كيسيليزوماب وبتاع.
دكتور محمد رأي حضرتك ايه يعني كيس كده نستخدم سنجل ايجنت اور كومباينيشن ديبندنج اون كل حاجه متاحه؟
لا هاف اول I would go for nivo-ipi.